Hello, everyone. Thank you for joining us today. This is our virtual speaker series, Spotlight on Deaf and Hard of Hearing Healthcare Professionals. This program is under the Healthcare System Transformation Project, HSTP, under the Commission on the Deaf and Hard of Hearing in Rhode Island. My name is Christine West. I'm the project manager for the HSTP program. And with us today is Dr. Chris Moreland. He is an MD, an MPH, an FACP, also an associate professor in the Department of Internal Medicine, also associate residency program director. He works at the medical school at the University of Austin, Texas. Thank you. Very nice to see you, Christine. Thanks for supporting our work here in Rhode Island. Firstly, I'd like to know a little bit more about who you are, where you grew up, a little bit about your educational journey, any barriers that you might have faced along the way and how you overcame them, and what led you into becoming a doctor in the first place. Sure. Well, I was born and raised in Texas, deaf since birth. Everyone in my family can hear. And when I was 2 years old, my parents noticed that I had a language delay. So they contacted a number of experts and determined that I was deaf. My parents decided to raise me in a bilingual, bicultural approach, so I learned both sign language and spoken English. I went to school with interpreters. I ended up going to college here in Austin, Texas. Go Longhorns. Oh, Longhorns. Oh, yes, it's in my blood. So I was an undergrad here for 5 years, and it was a tremendous experience. I really didn't know what I wanted to do professionally. I tried a number of things in college. I started out with theater, which was a great experience. I learned all about backstage crew, stage settings, and at the same time, I also learned about people. I learned a lot about character development. And I didn't see this as a long-term career, so I did move on. A friend of mine invited me to join him at a research lab here at the University of Texas. And we were studying language, linguistics, and early childhood language acquisition, which was fascinating. I learned a lot about doing research. I learned methodology, various approaches, how to actually conduct research and interviews. And it was wonderful. It was a great experience. I really developed a lot of skill in science and how to come up with a hypothesis. Still, I felt like this was not a complete match for me. There was something missing. So I continued on my journey through college, and I decided to think about medicine. I know there are different specialties and different roles for people in medicine. I know empathy is an important skill to have. Obviously, science, research, teaching. There are so many things one can do in the field of medicine. So I decided to go ahead and approach that. I started taking all the prerequisite courses that you need to get into medical school. And then I started applying for medical schools. I was invited to be interviewed at a number of schools, and that experience, interviewing with those medical school faculty and staff, was challenging for a couple of reasons. It was my first time ever interviewing for a professional position. I asked for an interpreter, and I had to ask for an interpreter without them really having any experience with interpreters, which meant that I had to learn how to make that request. I had to communicate that to them. Some schools understood automatically. They had no trouble providing an interpreter for the interview, and other schools said, well, we're going to need to look into that. Ultimately, it worked out well. Now, during those interviews, what a great experience that was. I met doctors, I met professors in the medical school, educators, and I learned how to get a sense of what the medical work will look like. And I did ask my friends who were deaf how they worked with interpreters. I also learned how to ask clarifying questions. I got a pretty good picture of what the profession might be like. I guess one barrier or challenge, I guess I'd say, is that here I was already nervous about having an interview to get into medical school, but that was compounded by the fact that I had to educate them, the interviewers, on the interpreted process. I'm sure, they were wondering, could a deaf person be successful in medicine? As it turns out, it worked out well, and I was accepted to medical school in Houston, at the University of Houston, which I attended for 4 years. When I got into University of Houston Medical School, I found out that they already had a deaf student who was in his 4th year. We met. He also worked with interpreters. And so it was a good thing that the school had already used interpreters. After I was there a year, that student graduated, so then I was the only deaf student in the medical school. Another challenge was educating my classmates, my professors, some of the doctors that I worked with, nurses. And so I had to learn how to share information about interpreters in such a way that it indicated that I was still perfectly capable of working in the field, that this was not going to be a problem. And I worked with a wonderful group of people, very, very supportive people. It was a great classroom environment. I do remember the first time I was working with a patient. This was my 3rd year. And that's when students generally start getting some clinical experience. So I thought in advance about how I might introduce myself and introduce my interpreter. And I knocked on the door and entered the room and said hello. I introduced myself. I explained that I was deaf, that I can speak and sign, and that I also use a sign language interpreter. And I kind of went on a bit too long, I guess. The patient seemed a bit put off, like I had given too much information. So I learned my lesson. The second time, I decided to approach it differently with my next patient. I entered the room, introduced myself, and said, "Hi, how are you?" That didn't really work out well either, because they kept looking at the interpreter and wondering who the interpreter was. Right, the elephant in the room. Exactly, that patient just kept looking at the interpreter. And so I realized that approach hadn't worked, but the third time was a charm. I entered the room. I realized this isn't about me. This isn't about the interpreter. The most important person in the room is the patient. So I stopped overthinking the situation. I entered the room, introduced myself. I explained that I was deaf. This is my interpreter, and immediately said, "How are you?" And that worked out beautifully, and I've been using that approach ever since. So I graduated in 2005, and I've been using that approach my entire professional career. When I finished the program there, I went to Sacramento, California. And that's where I did my internal medicine rotation. It was a wonderful residency. I had interviewed with several programs, but this one was extremely welcoming. I mentioned that I was interested in working with deaf people, and they said, we want to hear more about what your interests are. I ended up staying there for 3 years, and they were extremely supportive. I worked in the clinic. I had deaf patients as well as patients from the general population. And I did work with an interpreter. The interpreter was fantastic. We had to figure out how we fit into the system. The program itself wasn't really under a medical school per se. So they didn't know where to put the interpreter, where the interpreter fit in the system, who the interpreter worked for. There was an interpreter service, there was my program, there were my directors, but it was a little bit awkward determining where the interpreter worked for. Everyone was more than happy to have the interpreter, they just didn't quite know where to put the interpreter. So I finished that program in 2008. I stayed on at UC Davis for another couple of years doing academic training, doing curriculum development, improving my teaching skills, and then in 2010 I moved back home to Austin. I actually worked in San Antonio, and I worked as a hospitalist there, which means I worked only in a hospital. And when anyone was hospitalized, I would work with them. I was also faculty at the medical school, and I became the associate director for the residency program there, and worked there for several years, developing curriculum for residencies. 3 months ago, I moved here to Austin, and I plan to settle here. I work at the medical school in a very similar role as my previous hospital, as a hospitalist, as associate director for our residency program. Well, thank you so much. Thank you for sharing that information. You were talking about working with an interpreter. And I did interview several doctors for this project. And I noticed that those doctors who use American Sign Language emphasize the importance of having a designated interpreter, or a DI. I didn't pursue a lot of questions at the time, but I would like to ask you more about that. And maybe you could tell folks who are watching about this model of the DI, designated interpreter, for a deaf professional, DP. That person works with the professional in the workplace, and I'm hoping you can expand on the process, how that works, what the relationship is like, and maybe if you could just tell us more about the everyday life. For example, I do remember one interview. This person, by the way, mentioned your name, as several people have in this interview series. Every time your name comes up, you get very positive reviews. You are the role model to so many. Anyway, this one doctor mentioned you, and they talked about your workshop on the Code Blue. And I wonder if you wouldn't mind talking about that, how you work with interpreters to maximize that relationship, and what the relationship looks like for those folks out there who are watching this interview. Thank you for asking me. Let me just go back a little bit to medical school. When I entered, the school had a contract with an interpreting agency. And the agency realized that I would need consistency within the interpreter team because of vocabulary, because here I am learning, and the interpreter would be learning as well. So that would be a daunting process. So they decided to provide me with a team of interpreters where we could work out signs, and they would stay with me consistently through the program. So we would learn concepts and signs together, and it would stabilize my education. That worked out really well, and I had a great team. There were a few interpreters. There were 2 primary interpreters, and then there was a pool of backup interpreters. One of the primary interpreters was from the area and had a lot of experience working with the medical student that preceded me. The second interpreter, they actually advertised to get him into the state. And that second interpreter has been working with me ever since. Almost 20 years. The concept of a DI, a designated interpreter, is just critical. Especially when working with a deaf professional. You probably know Dr. Peter Hauser. He came up with the concept quite a while ago of having a designated interpreter model. There's been a lot of discussion about what that means exactly, and it depends on the work environment. I think what's key is the relationship. It's a team relationship, and you have to be clear on what that is. The designated interpreter, it's not just any interpreter that arrives on the job. I'm working with Todd Agan now, and that's the person I was talking about that I've been with for so long. We've talked about this quite a bit. I think what makes a good DI is the relationship. It develops over time. It's based on communication, on negotiation, on a shared understanding. That's what creates the relationship. For example, on a daily basis, as a hospitalist, I'm inside the hospital. I come to work in the morning, and right away I may get a list of patients. I'll meet with my team, the residents, the students. We'll have a discussion, and then we'll do the rounds. We'll start visiting patients. And as we're doing the rounds, we have to develop a plan. I'm also teaching residents and students. We may have a pharmacist involved, a nurse involved. It's a fantastic team. And the interpreter is part of that team. I may get a phone call from a pharmacy or a nurse, and my interpreter will interpret that phone call. If my team has a discussion about a patient, the interpreter is part of that discussion. So the interpreter has to be very flexible. There may be a one-on-one where I'm giving feedback to one of my students, or I might have 2 interpreters throughout the day in various situations. The interpreters have a lot of different duties. So with my interpreting team, it's very important to be compatible. We discuss everything every day. We give each other feedback. It's not just me giving them feedback, they give me feedback. And we talk about, what could we have done differently in a certain situation from their perspective. And I might say, how could we solve that issue to prevent an issue from arising in the future? How can we, as a team, communicate better? So we talk about that communication in a very proactive way. I want my interpreters to relate with my hearing peers in the hospital as well. So we talk about all these things, and it doesn't happen overnight. It builds over time. It's almost like a marriage. So that relationship building is key, and that's what defines the DP-DI relationship. You talked about the workshop, the Code Blue workshop, and that was so much fun. As a hospitalist, it happens. There'll be an emergency situation. A patient gets very, very sick quickly, and we have to intervene to support them in an emergency, and that's called the Code Blue situation. As the head doctor, I have to direct that situation. The interpreter accompanies me, Communication has to be rapid and instant. Of course, we plan in advance what the code blue is going to look like, what will be happening in the room, where should the interpreter stand. If there are 3 or 4 people talking, the interpreter needs to let me know who's talking so I know where to look. Wow, thank you for that. I agree. That relationship between the DP and the DI is just critical and involves so much negotiation to work out the details. And I know it doesn't happen overnight. I imagine with a deaf professional, it evolves over many, many years, and it requires a lot of discussion and a lot of agreements and planning, as you mentioned. What an interesting process. Thank you for sharing that. For those watching, I think that's really valuable. Now, I wonder if you wouldn't mind telling us a little bit about some of the benefits of having deaf and hard of hearing people as healthcare professionals in the medical field. How might it benefit the deaf community and the hard of hearing community, but also the hearing community at large? Also, I wanted to add another question to this. I did a little bit of research about you before this interview, and I know you were involved in a project called Deaf and Hard of Hearing Pipeline Barriers Project. And I wonder if you could talk about that project as well. Sure. Well, I think the benefits is to have deaf people benefits of having deaf people and hard of hearing people is for the direct communication with their patients. That direct communication is priceless. You can have deaf nurses, deaf doctors, deaf pharmacists, social workers, counselors, and having that direct language without the need for an interpreter is a very rich experience. For me, when I worked at the clinic and now at the hospital, I work directly with my deaf patients. It's very inspiring for me to be able to communicate directly. And it's great for my patients to have direct access to communication. And it's not just linguistic. It's about shared understanding, a relationship based on a shared challenge, a shared experience in life in general. And I can advocate for my patients. Maybe if I refer a patient to another hospital, I can connect with the doctor there and talk to them about the best way to provide interpreting services, where they can get interpreters, when they should have interpreters, and so forth. Oftentimes, I'll give consultations to other doctors, and they're having a specific challenge with a deaf person. For example, recently I had a doctor ask me how to work with a deaf-blind patient. And of course, ensuring access during the day and at night was critical. So we came up with some creative solutions to solve that problem. As deaf professionals, we can really improve the healthcare for the deaf community. And we can also support access to other healthcare providers who are hearing. You know Dr. Michael McKee. I believe you interviewed him previously. He's done quite a bit of research on the benefits of working directly with deaf and hard of hearing clients, patients. And the diversity is another issue, which we'll talk about. But there's so much evidence that says having a diverse workforce in healthcare is valuable. You may have someone from another country. But when we bring in diversity, it's better for everyone. It's not just because we are serving people and doing the right thing, but having a diverse group of professionals makes us all more creative. We come up with much better solutions and answers to questions. It improves healthcare overall. The entire system benefits. So I can't overemphasize the value of breaking down those barriers. if anyone wants to get into the healthcare profession and they're deaf and they're maybe thinking that they can't do it because they've had some frustrations in the past or someone has told them that they can't do it, it's simply not true. It's a very different world now than it was 40 or 50 years ago. There's so much more access. We have technology, interpreter services, legal support, awareness. And there's really no reason why someone who is deaf or hard of hearing can't work in any field, especially in any healthcare field. And back to diversity for a moment. You know, we talk about diversity. We were funded at UC Davis by the HRSA grant for diversity in the workforce, doing research on that. And we surveyed deaf and hard of hearing people who had applied to medical school and other healthcare professional schools. And after the surveys, we conducted some interviews on their experience when interviewing with those programs. And that information will help us figure out how to address the barriers that they encountered and also utilize some of the strategies that they used to figure out what works and what doesn't work. And we intend to use that information to be used universally to educate the universities as well as individuals. Thank you for that information. Can you tell me when that research will be completed and available? Right now we're analyzing the data and we're writing a paper, and that'll be published this year or next. Thank you. I'm looking forward to seeing that. I noticed a comment, and also from just other interviews, you describe people describe you as a role model. People talk about your research background and how you've been involved in leadership, teaching. And I'm starting to see a theme here. What I'm noticing is that collaboration seems to permeate all of your work. Collaboration with interpreters, as you mentioned, your work with DIs, collaboration with different medical providers that you just talked about, across disciplines. Also, you mentioned collaborating with patients. And I'm noticing a theme of collaboration, as I said earlier. I'm wondering, is this from your experience with theater, way before you entered the medical field back in college, the notion of empathy? Can you talk more about collaboration and how does that affect your work? What a great question, Christine. I have to reflect on that. You're absolutely right. Throughout my career, I've really noticed that I do so much better when I work with other people. We often feel like we have to do everything ourselves. And we study for exams by ourselves. We figure out how to answer questions by ourselves. And actually, we need to use each other. We need to support one another. And that could start in college, in the workplace, in medicine. For the last 20 years or so, I've been very interested in interprofessional training. Right now, we have medical school, we have nursing school, pharmacy school. Each program is separate. But the idea of having everyone together and learning together is so valuable. We learn from one another. We develop materials together. And that's a collaborative process that I think is really important for improving healthcare for everyone. Instead of having one perspective, we need multiple perspectives. That's how healthcare improves. I consider interpreters part of the healthcare team. the interpreters themselves, because they're trained as communication experts. They can observe a situation and figure out how best to support the communication. And I value that experience. So yeah, collaboration is key. Working alone, you just can't be as effective. Thank you. I'm curious about one webinar that I've noticed that you did with Stanford School of Medicine related to cultural humility in healthcare. And I'm wondering if you'd be willing to talk about what that means. I'm very interested in your definition. Thanks for asking me about that, Christine. Medical education does talk about cultural competence, and we all know what that is. That term really talks about a behavior or a set of actions. And if you do certain actions correctly, then you are culturally competent. You meet the needs of that person with a certain cultural background. And that way you can work better with a diversity of populations. But cultural humility is different. It's not about specific behaviors. It has more to do with attitude, a way of thinking about interacting with people, a lot of self-reflection, an ongoing openness to ideas, a willingness to look within yourself and ask yourself, how can I approach this person as an individual? How can I better understand this person's perspective, their background, what's important to them right now? So cultural humility refers to that. It has a lot to do with attitude. And that attitude of openness, curiosity, the desire to learn about the other person. So that approach has become more valuable these days because with our healthcare professionals, we're realizing we really don't fully understand the people we serve. And how can we better understand them and meet their needs? And a lot of that has to do with attitude. Thank you for explaining that. Here in Rhode Island, part of our project has to do with healthcare access. What we've noticed is several people in the deaf and hard of hearing community will go to the doctor's office for preventative care for difficulties, and they often have a difficult time because the doctor doesn't realize they have a legal obligation to provide an interpreter, or they refuse to provide one because they don't want to pay for the interpreter. And a lot of people in the community end up going to the emergency room instead for their primary care. And we notice a lack of the patient-doctor relationship or patient-provider relationship. And research shows that there are better health outcomes when a patient has direct communication with their primary care provider. I'm curious about your thoughts on this topic and how we can improve the patient-provider relationship in general. Well, the key, and by the way, we are seeing more people in the United States who sign and are working in the healthcare profession, which is great. The deaf doctors, deaf nurses, other healthcare professionals, so that direct communication is provided, and it's so valuable for deaf patients. It's also important to identify people in the community who have a need for that professional and make sure that we work hard to strengthen the community and support the environment so that people do come to the medical professionals. We don't have enough deaf professionals in the field yet. Hopefully down the road we will. We definitely want more, and we encourage people to apply. There are other ways to support a positive environment for deaf people in the deaf community. The emergency medicine, the ER, is very, very good for healthcare, but it's not the appropriate place for preventative medicine or primary care. you're much better off going to your healthcare professional. And one way we can help people get to those professionals is to provide services, communication access. And we do need to advocate more on that. We need to be more visible. We're involved with healthcare, and it doesn't matter whether it's a social worker, a psychologist, any kind of doctor, a nurse even, a pharmacist. We've got to speak up and provide information. And that's what our project does, is get information to the community to provide access to deaf and hard of hearing patients. And we talk about what that means. You know, oftentimes people don't know what they don't know, and that's a big problem. There is a legal requirement to provide an interpreter, but some people don't know that, and they make an assumption. So we have to do a lot of demonstrating and showing people what access looks like. You probably know about the Organization for Deaf Professionals, Deaf Medical Professionals, AMPHL. That started in 2001. And that is an organization for healthcare professionals, including veterinarians, any kind of professional, nurses, doctors, pharmacists, anyone who wants to become a professional in the field of medicine who is deaf or hard of hearing. And AMPHL does a lot of advocacy, which is very beneficial. I got so much from working with this group. And it gives you a good idea of what healthcare might look like. Here in Rhode Island, we do have a medical school at Brown University. It's a wonderful school. And we have been talking to other doctors about some of the technical standards of admission to medical school. And now we're getting more into functional standards versus the technical standards. What advice do you have for medical schools to invest in deaf and hard of hearing healthcare professionals, to recruit them, and to value diversity? Deaf and hard of hearing people in the medical field, how would you advise people and advise programs to make themselves programs more friendly and more welcoming to deaf and hard of hearing people? It's a great question. And there are a lot of approaches that work. One thing that's key is a concept that you mentioned with diversity. The medical school's educational system sort of sees diversity as race, ethnicity, religion. And we have to emphasize that deafness is part of that too, part of diversity. Deafness and the concept of disability. And I'm not lumping deafness and disability together, but the perspective of people who are deaf and the perspective of people who are disabled does fit with the concept of diversity. And including disabled and deaf people in the definition of diversity and that concept makes a lot of sense. The AAMC, they oversee medical schools in the United States, and they also confer the medical degrees. And we're noticing an emphasis lately on the importance of inclusion. So diversity is having a much broader definition. And so more and more people are being included in the definition, which is great. And that's having a trickle-down effect in medical schools in general across the country. So you can influence your local medical school by offering to go there and give a presentation to medical students. Bring deaf or hard of hearing community members who can present on what their experience is, what it might be like to have a deaf patient. How could the medical students support healthcare improvement for us, the deaf community? Medical schools are starting to realize that it's not just a place of study, it's a place of inclusion and learning. So that's one way, is to actually offer to go give a workshop or a talk at your local medical school and nursing school as well. Another approach is contact the school's diversity office. One school that I worked at had a diversity council, and we advocated for communication access for anything that might come up. And for anything that there was a challenge, we would try to present a solution on access. So we took a lot of action, and we provided a lot of support to the school in general. So that's an example of more collaboration, Chris. I wanted to talk a little bit about COVID-19. I'd like to know what your experience has been so far, what you're seeing with COVID-19 now, and is there anything particularly striking? Do you see disparities in terms of access? And overall, what are you noticing related to COVID-19 in your everyday work? Yes. We already know that deaf and hard of hearing people in general have a communication disparity, and that affects access to doctors' offices, calling for appointments, making sure that they understand their prescriptions and procedures. And so there is an information disparity. And now, with that communication disparity, we're adding on to this the fact that doctors and nurses are all wearing a mask. And there's a limited number of people who are allowed in the hospital. So if someone does go into the hospital to spend the night, other people from the family aren't even allowed to visit, or there's a very limited number of visitors. If they have COVID-19, they can't have any visitors, except for over the telephone, VRS. So a lot of times family and friends support us as deaf people. And so without that support, that really has an impact on health outcomes. It has a big impact. And I am seeing some challenges right now. So we do have people with COVID. A lot of people are very concerned. They're afraid. They're not sure exactly what it all means, whether or not they'll recover. How can they communicate with the people who are helping them in the hospital, the doctors and the nurses? When they come into the room, especially the room of a COVID patient, they're completely covered from head to toe with masks and shields and gloves. It's very hard to see the doctor's face. Even the interpreter will be completely covered and very hard to see, so they'll have to sign clearly to be understood. We have to be very, very overt in our communication. We have to plan ahead, of course. Dr. McKee, and there's another ENT, has talked about this as well. How to communicate during COVID-19. There's a webinar on this. And the most important thing is to plan in advance. For example, if I need an interpreter or any other kind of a communication technology, I need to be ready to inform the medical provider right away what my needs are. I need to have them very clearly outlined. And then if a doctor's going to be leaving and going on vacation for a week, we need to inform the replacement doctor what our needs are as patients. Even when a doctor goes home at the end of the day, they need to pass on information about the patient so that the next caretaker is prepared. So we can't just ask community members to take responsibility for all the communication. Self-advocacy is important, but we, the medical providers, need to improve our system to identify communication needs. Too often we make assumptions. If the person seems to understand us, we're happy with that, but everyone is different. Everyone has their preferred way to communicate. Spoken English might be fine for one person, ASL or an interpreter might be better, maybe writing notes. We need to be open to people and give them what they ask for based on what they need. It's really important to work with the patients. You make a good point. I wonder, when you ask for your communication preference, do you see that in healthcare situations and along your journey, when a person gets to the hospital, do they have instructions, the receptionists have instructions on how to assess the deaf person's communication preference? How do you determine that? Well, every hospital and every clinic has a different approach, and that is actually an issue, is the fact that we're not standardized. So we have to figure out how we're going to handle a situation. And we really need to provide more standardized approaches. First of all, we start by asking. Not every person does ask the question, but we need to ask the patient. Hospitals now, each time a patient goes into the ER or the hospital, the nurse will typically ask, what language do you prefer to use? English, Spanish, or what language? And we should say, what language do you prefer to use and what communication method do you prefer to use? We don't do that often enough. If you look at it from the patient perspective, I would encourage the community to write down 4 or 5 things that they might need when they go to the hospital and have that piece of paper ready. And I realize, when you're sick, you forget these things. If you're diabetic or whatever and you're really not feeling well, you want to have this list ready. And let the provider, let your family know, let your caretakers know so that the hospital is ready for you and knows exactly what to provide to you. If you have that information ahead of time, again, preparedness is so important. You'll be more likely to get the right information, and your healthcare team will be able to serve you better. That's a great idea. Having to do with healthcare disparity. I know that there's research on this. What are you seeing with the deaf and hard of hearing community in general? Well, we've done quite a bit of research, probably 20 or 30 years worth of research, and it shows different kinds of healthcare disparities. A lot of it has to do with knowledge. A lot of deaf and hard of hearing people, our research tells us, if you compare them to the general public hearing people in the United States and in other countries as well, for example, the deaf community may have less knowledge about things like HIV, cancer, heart disease. And that's a problem. If we have less knowledge about something like HIV, it makes it harder to prevent. Also, things like vaccines. The flu vaccine, the HPV vaccine. People don't really know what that means. If people understand what things mean, they're more compliant. And they're more likely to accept those kinds of interventions. So those, among many reasons, are concerns for us when it comes to healthcare disparities. We'd like to have that information be accessible, whether it's through captions, reading, ASL. There are different ways to share that information. And we can certainly help make sure that the community develops more knowledge and we're more able to advocate for ourselves. I'm assuming then that maybe there are some kind of healthcare educators in the communities who know sign language. Seems like that would be a huge benefit to provide that kind of education. What do you think? Oh, absolutely. A lot of communities do have these healthcare educators. The concept is these are healthcare workers. They are from the community that they serve. They know the community. They understand the community. And they're trained to advocate for the community. And they serve us as mediators. They not only understand the people in their community, but they understand the healthcare system. That role is so priceless. Community healthcare workers are just vital. We don't have enough, not even close to enough. Thank you. I think that's pretty much it, unless there's something that you'd like to add before we close. Is there anything at all you'd like to add? Well, I do want to I mentioned the challenge with wearing face masks during this pandemic. They do make face masks with a nice clear panel over the mouth. And when these were made, there were enough of them were not made, but they work so much better than a solid face mask. So professionals really need to advocate for more of these face masks. We need more accessible face masks so that lip reading is easier. The benefit is not just for deaf and hard of hearing people, but being able to see the face is great for children who are patients, for adults, because it's a little bit scary to have somebody walk into your room and most of their face is covered by a mask. But if you can see them smile, you see their humanity a little bit, it's really important. It's something we need to advocate for. I know COVID-19's been around for quite a while, and it's hard to predict when it's going to end. Well, yes, COVID is going to be with us for quite a while. It's important that we figure out as soon as possible how to improve our communication with the medical system and in communication in general. Thank you so much. I really, really appreciate you putting this time aside and telling us about yourself and your journey. If people want to contact you, would that be okay if I put your contact information at the end of this video? Or so that if people have questions, they could reach out? That's fine. People are more than welcome to contact me at my email address. Great. Well, once again, I can't thank you enough for joining us today. I really enjoyed this conversation, and I appreciate your supporting our work here in Rhode Island. So nice to meet you. Thank you. This was really wonderful meeting you too, Christine. Okay, well, take care now. Bye-bye.